Good morning, class. So I'm Dr. Daniel. I'm an associate professor of gastroenterology at the American University of Beirut. And today's lecture is about inflammatory bowel disease. So these are the learning objectives. We will describe the epidemiology of inflammatory bowel disease. We will list the symptoms and extraintestinal manifestations of IBD. We should differentiate between ulcerative colitis and Crohn's disease, which are the two main inflammatory bowel diseases. And we should also describe the principles of management of IBD, including the surgical approaches. And lastly, but very briefly, we will go over the medication used for the treatment of IBD. So briefly, this is the outline, the introduction, the epidemiology, the clinical presentation of each of the two diseases that comprise inflammatory bowel disease. We're going to discuss etiology and pathogenesis, especially the extraintestinal manifestation, and finally, a little overview of the treatment. Inflammatory bowel diseases are divided between Crohn's disease and ulcerative colitis. So there are two groups. Either it's Crohn's disease, either it's ulcerative colitis. Sometimes the characteristics of the patients do not fit either Crohn's disease characteristics or ulcerative colitis characteristics. This is where we call the patient as having inflammatory bowel disease unclassified. So IBD or IBDs are conditions characterized by chronic relapsing immune activation and inflammation within the GI tract. But this inflammation could also be located outside the GI tract. This is what we call the extraintestinal manifestation of IBD, and we will be developing later on. So whenever you are talking about inflammatory bowel diseases, there are two inflammatory bowel diseases. Either it's Crohn's disease, either it's ulcerative colitis, either for a temporary moment, it will be called IBDU because they do not really, the patient does not fit either Crohn's disease characteristics, either ulcerative colitis characteristics. Inflammatory bowel diseases affect between 1.6 to 2 million people in the US. Was noted in a survey published in the New England Journal of Medicine in 1996. Ulcerative colitis and Crohn's disease have similar prevalence, and approximately 70,000 new cases of either ulcerative colitis or Crohn's disease are diagnosed annually in the United States. So let's take a closer look at the epidemiology of IBD. There's what we call the northern to southern gradient in terms of incidence. What does it mean? It means that if you look at the map of the world, there's a higher incidence in the countries that are located in the northern hemisphere, which are developed countries, mainly the United States and Europe. And the incidence is less when it comes to Asia, when it comes to Africa. So this is what we call the northern to southern gradient, and the incidence of IBD is higher in developed countries. So, and now what about the peak age at onset? As any other autoimmune disease, we know it's the disease of the young. So there is a first peak of onset between 15 to 30 years of age. But the characteristics of IBD is that there is another late onset peak between 60 and 80 years old of age. So these are diseases not only of the young people, but they can also manifest themselves as a new diagnosis in the elderly. And this should be kept in mind. What about the male to female ratio? As any other autoimmune disease, there is always a slight female preponderance when it comes to the prevalence, and IBD is no exception because there is a slight female preponderance with a female to male ratio going from 1.1 to 1.8 female to every male. There is also a racial and ethnic difference in the incidence. What you should keep in mind that the incidence of IBD is always across the globe higher in whites and higher in Jews. Moving on to the clinical findings. We will start with ulcerative colitis. As the name indicates, this is ulcerative. There are ulcerations in the mucosa that we will see on endoscopy, and this is colitis. Colitis, that means it involves only the colon, and the small intestine is not involved. And this is the main difference between Crohn's disease, which can involve any part of the intestine, whereas ulcerative colitis only involves the colon. So when it comes to ulcerative colitis, it usually starts and always starts in the rectum. This is what we call the proctitis. Mind you that the rectum is the part of the colon that really is located between 12 to 15 centimeters above the anal area. So either the ulcerative colitis only is limited to the rectum, when this is where it's called proctitis. It can go a little bit upward and it goes up to the left colonic flexure. This is what we call left-sided colitis. And whenever the inflammation extends beyond the left splenic flexure or the left angle of the colon, this is where we call it pancolitis or total colitis. So in every ulcerative colitis patient, when you are presenting this patient, you should always detail the extent of the disease. Does the patient have proctitis? Does he have left-sided colitis, or does he have total colitis? Of course, you will find this information in the endoscopic report. So this is a very important feature of any IBD. It's all about the location. Where is the disease located? This slide summarizes the disease characteristics of ulcerative colitis. Again, it's limited to the colon. It's colitis. There's a continuous involvement of the mucosa starting in the rectum and extending upwards. And there is always rectal involvement. So proctitis, it starts with the proctitis and it can extend to the left side of the colon or involve the whole colon when it crosses the left splenic flexure of the left angle of the colon. Rarely it's associated with fistula and strictures, and the involvement of the mucosa is always superficial. So it only involves mucosa and submucosa. Endoscopy is the mainstay for the diagnosis of IBD, be it ulcerative colitis or Crohn's disease. This is a slide showing you the difference between normal mucosa to the right and an inflamed mucosa due to ulcerative colitis. You see on the left slide continuous inflammation, ulcerations, and congestion, whereas on the right slide you see the normal colonic mucosa with the underlying submucosal vessels. How does ulcerative colitis present? As long as it is involving the rectum, you know, it's the lowest part of the colon, so it goes without saying that bleeding, diarrhea, mucus in the stools, rectal urgency, and tenesmus are the mainstay of clinical symptoms. Why? Because, you know, the rectum has the sensors. This is due to the mechanoreceptors in the rectum. This is how we feel there is stool coming into the rectum, and we have the urge to really evacuate. So whenever you have inflammation of the mucosa of the rectum, there's a continuous urge to defecate, although there's no stools present. So the patient will tell you, I have tenesmus, I feel going to the bathroom multiple times, and there is no stool going out. Sometimes mucus goes out, sometimes blood goes out. And why does mucus goes out? Because inflammation increases the secretion of mucus by the colonic mucosa. You know, if it wasn't for the mucus, the stool would have ulcerated the colon, because the mucus is a layer that helps the stool to slide through the mucosa of the colon up to the rectum before it gets evacuated. And whenever you have inflammation of the mucosa, there is an increased amount of mucus that is secreted. Usually the mucus that is secreted we do not see in the stools. Whenever the patients start to see mucus in their stools, like I tell them, like the mucus in the nose, when you are blowing your nose, this is where you should suspect an inflammation. Of course, having what we call the rectal symptoms of bleeding, diarrhea, loose stools, mucus, and bloody emissions, along with extraintestinal manifestations, be it in the articulation, be it in the eyes, as I show you later on, is also suggestive of the presence of inflammatory bowel disease. Abdominal pain is uncommon. Why? It's not that common because simply the most frequent location is either proctitis, either left-sided colitis, and usually the pain component in this location is not predominant. Nevertheless, when you have a pancolitis, again an inflammation extending beyond the left hepatic flexure, abdominal pain might be more frequent. There's also what we call the general symptoms, malaise, lethargy, nausea, fever, weight loss. When the disease has been going on for a long time, you know, like any other chronic diseases, it will be associated with an impact on blood, on weight. And of course, when you have in the history of a patient a remitting and relapsing course, for instance, diarrhea, abdominal pain, mucus discharge that really waxes and wanes, this is also suggests chronic inflammatory bowel disease. This slide shows you how can we evaluate the activity of the ulcerative colitis. So there are three ways to evaluate the activity. One is clinically based on bowel movements, their number, the presence of blood, and the presence of fever and tachycardia. These are clinical parameters. So the more fever you have, the more tachycardia you have, the more blood in the stool you have, the more number of bowel movements, the more severe the ulcerative colitis is. And there's also a biologic way to evaluate the activity of ulcerative colitis based on anemia. Since it is a inflammatory condition causing ulcerations, you understand that you will have bleeding, and bleeding will lead to anemia. So the deeper the anemia, the higher the activity. And also, since these are inflammatory conditions, the higher ESR and CRP, which are the inflammatory biological parameters, the higher the activity of the disease. And a third way to evaluate the activity of ulcerative colitis is based on endoscopy. So the more severe the inflammation in the colon, based on the presence or not of erosions of ulcerations. So you can classify the activity either mild, when only erythema is there with a decreased vascular pattern and some granularity. Whenever you start having a bleeding and really small ulcerations, you will have a moderate activity. And whenever there is spontaneous bleeding and ulcerations, this is where you have severe activity. So bottom line, the severity of ulcerative colitis can be evaluated clinically, biologically, or endoscopically. What happens if we do not treat an ulcerative colitis, which is inflaming the colon, ulcerating the colon? As you can really imagine, we can have severe bleeding if the ulcers go very extensively, and the bleeding would be very severe, requiring transfusions. The long-standing inflammation of the colon, especially after 10 years of evolution, will give rise to the possibility of having what we call dysplasia. Dysplasia is the transformation of the colonocyte into pre-neoplastic cells that will give rise to later on to colon cancer. So as you know, colon cancer is a very prevalent cancer. We know the lifetime risk of having colon cancer is 5% if you survive up to 90 years of age. And colon cancer in inflammatory colitis is increased compared to people who do not have inflammatory colitis. So the age is the bigger provider of colon cancer. But when you have in addition to your growing age, an inflammation in the colon, which is called ulcerative colitis, and this inflammation has been going on for more than 10 years, this is where you will start having around 1% per year the risk of having cancer. And compared to people who are only aging and who do not have ulcerative colitis, there's a 5-fold increase of developing dysplasia and colon cancer. And especially one rule of thumb, whenever you find a stricture in a colon with a background of ulcerative colitis, this stricture should have biopsies in order to rule out malignant cells, because every stricture on a chronically inflamed colon to ulcerative colitis could be a complication and could be really the hallmark of a colon cancer that has been already developed. And what I'm showing you here at the lower part of the slide is what we call the lead pipe colon. It's a colon that has been chronically inflamed and it has lost its hostration. You know, there are the Taenia coli that give hostrations to the colon, typically anatomically. When you have on a barium enema, that's what we call, we really fill the colon with barium and we take abdominal radiographs, you see that the colon has been transformed into a pipe. It's no longer this hostra, and this is also a hallmark of a chronic, long-standing disease in the colon. To the right, you see a stricture. You see a concentric decrease in the luminal diameter of the colon, and this is a very suspicious of malignancy. When you see this in the colon of a patient during endoscopy, you should always take biopsy to rule out a colonic neoplasia developing on top of dysplasia due to long-standing inflammation. Another field complication of severe ulcerative colitis is what we call toxic megacolon. Toxic megacolon is the acute distension and dilatation of the colon secondary to a severe inflammation of the colon. As you see here, you see that increased diameter of the colon, and as you can imagine, when the colon dilates a lot, you can have a perforation and this perforation can be deadly. So whenever you have a toxic megacolon developing from severe ulcerative colitis, this is a really strict indication for surgery, and you should remove the colon to avoid perforations and the corresponding septic shock, and that will lead to the death of the patient. So this is a very dreaded complication of ulcerative colitis if left untreated, and if the inflammation gets to a very severe point, the acute distension and dilatation of the colon will put the patient at high risk of colonic perforation. This is where the surgeon should be consulted. And one last complication for any inflammation in the body when it comes to the pediatric population, since the inflammation involves the guts and the gut cannot be used properly, so it will lead to growth failure, because it will lead to weight loss and inability to process the food within the intestinal tract. So inflammatory bowel disease developing in pediatric patients, on adolescent patients, bear not only the same complication and risk as in adults, but there's also a risk of growth failure in the pediatric population if the inflammatory bowel disease is not well managed and treated. Moving on to Crohn's disease. Again, this is the anatomic distribution of Crohn's disease. Crohn's disease can really involve the whole GI tract, from the mouth up till the anus. The most frequent location being the ileum and colon account for approximately 70% of the location of Crohn's disease. Sometimes there's only a localized colonic involvement. So the problem whenever you have an involvement outside the colon, it's very straightforward to differentiate between ulcerative colitis and Crohn's disease. The problem comes when in the 20% of cases where the Crohn's disease involves only the colon. This happens in 20% of Crohn's disease. And mind you also, you might have an upper localization of Crohn's disease in the proximal small bowel, in the stomach, in the esophagus. So the big difference again between Crohn's disease and ulcerative colitis is that Crohn's disease can involve the whole GI tract, whereas ulcerative colitis, as the name indicates, it's only a colitis, it involves the colon. This is the main take-home message that you should keep in mind. Summarizing the characteristics of Crohn's disease, it can affect any segment of the GI tract, as I already told you, from the mouth till the anus to the perineal area. So if there are two main characteristics of Crohn's disease that distinguish it from ulcerative colitis, is the involvement of the anal region with the development of fistula and abscesses in the anal region. I will show you later on some examples. And the location beyond the colon, in the small bowel, in the stomach, in the esophagus, and the duodenum. This is where it cannot be called ulcerative colitis. This is Crohn's disease. The IBD becomes called Crohn's disease if you have involvement outside the colon. Whenever you have an involvement of the colon only, how can you distinguish an ulcerative colitis from a Crohn's colitis? It's all about how is the mucosa involved. As I told you earlier, in the ulcerative colitis, there's always rectal involvement. Usually in Crohn's disease, the rectum is not involved fully. And the main hallmark at endoscopy of Crohn's disease is the segmental involvement with skip areas. What do I mean by this? You know, if you look at the picture of ulcerative colitis before, there was continuous inflammation of the mucosa. Whereas in Crohn's disease, here you see deep linear ulcers, here you see normal mucosa, here you see normal mucosa, here you see ulcers. Whereas in ulcerative colitis, there's a continuous carpet-like inflammation of the whole colon. Moreover, also there is segmental involvement, means that you might have a segment of the sigmoid, then another segment of the sigmoid which is not involved, then another segment in the left colon involved, and another segment in the right colon who is strictly normal. So the main difference endoscopically between ulcerative colitis is that Crohn's disease does not involve the rectum. Ulcerative colitis always involves the rectum fully. It's a continuous, whereas the inflammation in Crohn's disease is discontinuous, or what we call segmental, and it can affect any part of the GI tract from the mouth till the anus. And although it can be only located to the anus, to the colon in 20% of cases, and distinguish it from ulcerative colitis relies then on strictly endoscopic criteria. Again, the segmental involvement is characteristic of Crohn's disease when it comes to the colon, whereas the continuous involvement and the involvement of the rectum, of the whole rectum, is suggestive of ulcerative colitis. As I showed you, since most of the cases or two-thirds of the cases of Crohn's disease involve the ileum and the colon, the pain component is higher in terms of prevalence when it comes to Crohn's disease compared to ulcerative colitis. Again, why? Because proctitis does not give a lot of pain. It gives you a lot of fecal urgency and mucoid discharge and the sensation of false sensation of going to the bathroom, what we call the false urge. Whereas Crohn's disease, it's more about chronic abdominal pain and really loose stools, loss of appetite, an impact on the general well-being of the patient, losing his appetite and having weight loss. Mind you that the big difference between the small bowel and the colon is that the small bowel absorbs nutrients, whereas the colon is only a simple reservoir that takes out water and electrolytes and really produces stools, and it's a reservoir that really evacuates itself at least once every 24 hours. So whenever you have small bowel involvement, there's more severe impact of the disease on the absorption. This is where you will have more severe weight loss, and this is where also in the pediatric population, because you will need your nutrition to grow, you will have the failure to grow, as I alluded to earlier. Another characteristics presentation of Crohn's disease is what we call perianal disease of fistula. So any fistula developing in the anal region along with any inflammation in the colon and the small bowel is straightforward Crohn's disease and cannot qualify for ulcerative colitis. Sometimes the acute inflammation can involve the appendiceal area and the patient can present itself as in inaugural fashion. As a first presentation, it's a picture like acute appendicitis, and many times a patient present to the ER with a typical syndrome of acute appendicitis, and when the patient is being operated on, the surgeon, when he's resecting the appendix, he will notice there's an inflammation in the adjacent ileum, and this is where he will refer the patient after surgery to a gastroenterologist who will scope the patient and will diagnose Crohn's disease by demonstrating that there is an ileal inflammation. So acute appendicitis could be sometimes a presentation of Crohn's disease. This is something that you should be keeping in mind, and it's not really infrequent. Malabsorption syndrome, again, why? Because it involved the small bowel, and the small bowel is really involved with absorption of nutrients, and malabsorption will occur, and it will really increase the impact on the patient's well-being, on the patient's weight, on the patient's it will have, the patient will have more and will be more anorectic, more pain, and more weight loss. Again, the extraintestinal manifestation in a patient who have chronic abdominal pain, diarrhea, loss of appetite are also suggestive of Crohn's disease. This slide summarizes the disease characteristic differences between ulcerative colitis and Crohn's disease. When it comes to ulcerative colitis, the location involves only the colon, whereas Crohn's disease can be located anywhere in the GI tract. When it comes to distribution, ulcerative colitis has a continuous mucosal involvement starting in the lower rectum and extending upwards, whereas the distribution of the disease mucosally in Crohn's disease is usually patchy and segmental with skip areas of normal mucosa between two areas of inflamed mucosa. Rectal involvement is always present in ulcerative colitis, whereas rectal involvement is extremely rare in Crohn's disease, and if it is there, usually it does not involve the whole rectum, or it does not involve the lower part of the rectum. Mucosal involvement is superficial in ulcerative colitis, involving mucosa and submucosa, whereas it is transmural in Crohn's disease, and this explains why there is a higher prevalence of fistula in the Crohn's disease patients and strictures compared to ulcerative colitis patients. So what happens if we don't treat Crohn's disease? The first and most dreaded complication is the development of bowel obstruction from edema and fibrosis, and which will really tighten the lumen of the bowel and cause obstruction. Strictures, what we call the string sign that we see on radiology, are the major complication of long-standing Crohn's disease that has not been really controlled. Fistula is the second most important complication. What is fistula? Fistula is the communication between two organs that usually do not communicate. Okay, this is fistula and abscesses, which is the development of pus from the exteriorization of the stool that is contained inside the intestine to the outer part of the intestine. This is what we call abscesses. So fistula and abscesses are really classic complication and characteristic complication of Crohn's disease. When it comes to the pediatric population, again, because Crohn's disease has an involvement of the small bowel, which is important for the absorption of nutrients, this is where Crohn's disease is more detrimental to the pediatric population when it comes to comparing it to ulcerative colitis, which also can be related to failure of to thrive, but with less frequency. Malnutrition also is very important because you are not able to use and absorb the nutrients, and it will lead to impact on the general status of the patient. Colon cancer is also higher than the general population if you have colonic involvement by Crohn's disease. Abscesses are localized collections of pus within the tissue of the GI tract. They could be intra-abdominal when the fistula is really communicate the bowel into the abdominal cavity. They can be enterocutaneous fistula communicating the bowels with the wall of the abdomen, and they can be perianal fistula, as I will show you, communicating the anal region with the perianal region. This slide illustrated the development of anal fistula, which may communicate the anal region and the perianal region via a tract that really crosses the sphincteric apparatus. And the fistula can be communicating small intestine and to small intestine, or communicating small intestine into the abdominal cavity, or communicating colon into the bladder, and so on. So you can have all the imaginable tracts between different organs in the GI tract. And the bottom line is that whenever you have fistula and abscesses developing in the abdomen, always think of an underlying Crohn's disease. This is the main message. To the left, you see here the opening of an enterocutaneous fistula. It's a communication between the bowel and the abdominal wall and excluding pus. And to the left, this is the perianal region, and the anus is located in the black covered. And to the left, you see in the perianal region an orifice that is really producing pus, and this is called the secondary orifice. The primary orifice is located in the anus, and you have a tract that goes through the sphincter into the buttocks and really is extruding pus. So this is a fistula with abscess formation. And again, abdominal fistula, perianal fistula, whenever you have them, always think about ruling out underlying Crohn's disease. Now moving to etiology and pathogenesis. Etiology and pathogenesis of IBD are not fully understood. This is a beautiful slide that shows you in a very elegant way the three main counterparts to develop IBD. You should have genetic susceptibility, you should have an immune dysregulation, and there is also need for environmental triggers to trigger this dysregulation. So genetic predisposition, immune dysregulation, and finally environmental triggers that really blend the two predisposition, being genetic and immune dysregulation. To illustrate more the pathogenesis, we should look at the difference between IBD patients and non-IBD patients when it comes to mucosal inflammation. So in non-IBD patients, the mucosal immune system is one of inhibited immune response to luminal contents. So you know we have millions and millions of luminal bacteria, which is called the intestinal flora, that has really physiological beneficial effects to the organism. So in IBD patients, studies have shown that they have a different composition of this flora, and which might really perpetrate the inflammation. And we have also loss of tolerance to this flora in terms that this flora will be sensed by the immune system, which is dysregulated, and there is an inappropriate and exaggerated mucosal immune response to environmental factors, these factors being bacteria or being antigens present in food, presence in drugs, and so on. So this is the big difference between an IBD patient and a non-IBD patient, which is the presence of, again, of a dysregulated immune response to environmental factors to which in normal individuals does not react, and this is what leads to development of IBD and its related symptoms. This slide summarizes the environmental triggers so far known for IBD. Number one is the infection. So whenever you have an infection in the intestinal tract, your immune system will be triggered. So usually the idea is for the immune system is to be activated to take out the infection, the bacteria, the virus, and once the infection and is really resolved, the immune system should shut down. So if you are predisposed to genetic dysregulation, you have genetic susceptibility, and you face any infection, be it bacterial, be it viral, you will trigger your immune response, and this response that has been triggered by the infection that has really gone will continue by itself. And this is why infections are the number one predisposing factor to Crohn's disease again, or ulcerative colitis again, in predisposed individuals. Okay, so why? Because this is the explanation comes from the immune dysregulation that is genetically predisposed, we are genetically predisposed for, and the infection serves as a trigger for the system. Again, antibiotics, for the same reason, studies have shown that the higher prevalence found in inflammatory bowel disease in the northern hemispheres, where you have higher prevalence of rich countries. Who says rich countries says a higher accessibility to antibiotics? So using a lot of antibiotics early on in infancy might get you more at risk in the adulthood to develop IBD. And this might explain also that the northern to southern gradient in terms of incidence, because poor countries are located in the mostly in the southern hemisphere, and this also has been hypothesized by researchers that use of antibiotic and the exposure to antibiotics to good, healthy, and sanitary conditions might predispose or be protective against developing inflammatory bowel disease. Diet is also an interesting research topic, and studies, at least in animals, have shown there are inflammatory diets and there are anti-inflammatory diets. Mind you that these are not game changers, and diet cannot be the sole treatment of IBD. Okay, so but again, when it comes to pathogenesis, there are some anti-inflammatory diet again in predisposed individuals. If you are not predisposed, you don't get anything. NSAIDs have also been shown to increase the development of flares in people who are quiescent. You know, IBD, be it Crohn's or ulcerative colitis, are chronic relapsing conditions. If people are doing well on their medication and they take non-steroid anti-inflammatory drugs, they are put at higher risk of flaring or inducing a disease flare compared to people who have IBD and are not taking NSAIDs. So NSAIDs are really classic environmental triggers, and really inflammatory bowel disease patients should be counseled against using them if you have any painful condition, and really resort to some other families of painkillers. If there is a very important environmental factors, it's smoking. Smoking has been really clearly shown in all studies to really influence the severity of Crohn's disease, to influence the relapse of Crohn's disease, and to influence its response to therapies. So if you want to counsel your Crohn's disease patients and really do him good, you should really encourage him to stop smoking. Smoking has a paradoxical effect on both IBDs. So although it is really increases the severity of Crohn's disease, studies have shown that people who have quit smoking in 18 months ago have a higher prevalence of developing ulcerative colitis compared to controls who did not quit smoking in the 18 past months. So although smoking can be detrimental to Crohn's disease, it might have, at least in research papers, a protective factors against developing ulcerative colitis. Furthermore, nicotine, which is the main component of cigarette, has been shown to be able to reduce the activity of a severe ulcerative colitis. The problem is that the doses that you should use nicotine to control inflammation are associated with with the development of side effects. So, but nevertheless, this proves the concept that nicotine might be good for ulcerative colitis. It doesn't mean you should recommend smoking to your patient for ulcerative colitis, but you should for sure really counsel your patient who have Crohn's disease to really quit smoking, because smoking will be associated with the higher development of complication, and less response to the medication. And last but not least, if there is a environmental trigger that has been shown to really act in all autoimmune diseases, and IBD are not an exception, this is stress. Stress has been linked to the activity or the development of multiple immune-mediated disease, and inflammatory bowel disease are not an exception for that. This slide summarizes the evidence of a genetic susceptibility predisposing to inflammatory bowel disease. First, racial differences exist in incidence between white, black, and Asian. Asian people have the lowest prevalence of IBD. Why is that? Because they have different genetic background than white people, than black people. Furthermore, there are ethnic influences also on the development of Crohn's disease. As I alluded earlier, that Jewish people have a higher prevalence compared to non-Jewish people of having inflammatory bowel disease. And in the Jewish people, Ashkenazi Jews have a higher prevalence of inflammatory bowel disease than Sephardic Jews. Ashkenazi and Sephardic are like in Christians, Orthodox and Catholics, or like in Muslims, Shia and Sunnah. So the Ashkenazi Jews have a higher prevalence of Crohn's disease compared to Sephardic Jews. Again, highlighting the importance either of environmental factors or different genetic backgrounds. The most important evidence for a genetic susceptibility comes from twin studies, monozygotic and dizygotic studies. You know, monozygotic twins share the same genetic background, whereas dizygotic twins do not share the 100% the same genetic background. When it comes to clinical concordance, in monozygotic twins, it's only 67% for Crohn's disease and 20% for ulcerative colitis. So what does it tell you? It tells you that even if two siblings who are monozygotic twins, so real twins, and they do not have the same way of developing Crohn's disease or ulcerative colitis. For instance, one has a location in the ileum, the other will have location in the colon. And so the concordance is not 100%. And this also signals that not only genetic susceptibility is important, but environmental triggers are also, especially food, especially smoking, might be different between these two brothers or sisters, and this is why the concordance is not 100%. Furthermore, there is difference in the type of IBD. For instance, this concordance in monozygotic twins, it's 67% for Crohn's, but it's only 20% for ulcerative colitis. Why? Possibly also, maybe in ulcerative colitis, the environmental factors take on more of an importance. But again, just to highlight that it's a multifactorial genetic predisposition for an immune dysregulation and the role of environmental factors to trigger the system and make the inflammation kick in. Furthermore, the majority of genes that has been associated with an increased prevalence of IBD are usually associated with the HLA antigen, which we all know that they are antigen producing cells need the HLA complex to really present and really make the immune system know what is good and what is bad in order to protect the good and to really to hit the bad. So as long as IBD is an autoimmune disease, there have been multiple genes linked to the HLA locus on chromosome 6 and 16 that has been linked to a higher prevalence of inflammatory bowel disease, again highlighting the importance of a genetic susceptibility driving immune dysregulation. The most illustrative example for a genetic susceptibility is the presence of a NOD2 gene mutations. The NOD2 gene mutation are only present in 20% of Crohn's disease patients. But what do? This NOD2 gene codes again for a protein that is really important for the crosstalk between the immune system and the intestinal flora. So the mutation of the NOD gene might explain also the dysregulation or the immune dysregulation leading to a loss of tolerance to the intestinal flora and to development of Crohn's disease. Again, this genetic susceptibility or this gene does not explain the whole process because it's only present in 20% of patients. Again, genetic susceptibility is the main driver. This is not, IBD is not a monogenic disease, it's a polygenic disease. More than hundreds of diseases of locuses and genetic locus has been linked to a higher development of IBD, and it tells you that it is a really required condition, but usually not necessary by itself to trigger the disease, but it is a starting point. Another way of looking to the genetic susceptibility of developing IBD is looking at the familial pattern of inheritance. So approximately 10% of patients have a positive family history of IBD when they are diagnosed themselves with IBD. 2 to 10% risk is really described in first-degree relatives affected. So if you have a brother or a sister or a father or a mother, you have it between 2 to 10% risk of developing IBD compared to a person with the same age who does not have a history of having a father or a mother or a sister or a brother with IBD. There's a 20 to 50-fold increase in prevalence among siblings. Okay, so again, if you have a brother that has IBD or a sister that has IBD compared to someone who does not have a brother or sister, there's a 20 to 50-fold increase in the prevalence on the long term of inflammatory bowel disease. There's also a 50 to 100-fold increase in prevalence for children of both parents with IBD. So the worst thing is to have a mother and a father with Crohn's disease. You will have a 50 to 100-fold increase in the prevalence in your later on, and there's a 30% chance of being affected. So it really triples your risk if you have compared to one who has one father or one parent who has Crohn's disease. One parent with Crohn's disease, 10%. Two parents both, you have up to 36% chance of being affected by IBD on the long term. And this again illustrates the interplay between genetic and predisposing factor, because you inherit in a certain way some of the genes and then some of the predisposing genes to IBD from your parents. Moving on to extraintestinal manifestations of inflammatory bowel disease. So extraintestinal manifestations of IBD are relatively frequent, and as I told you earlier, that it is not only an inflammatory condition of the bowel, so it's a systematic inflammatory condition, and if you have a dysregulated autoimmunity against one organ, you have a higher likelihood of having a dysregulated immunity against another organ. So almost all organs in the body can be affected by an inflammatory reaction or an inflammatory condition when you have inflammatory bowel disease in the bowel. So the most prevalent one are after stomatitis, episcleritis, uveitis, arthritis, and erythema nodosum and pyoderma gangrenosum. And the way we distinguish between extraintestinal manifestation is, are they related to the activity of the disease, or they can go and really evolve in a fashion independent of the disease activity. So this is a way of distinguishing between extraintestinal manifestation. So whenever you have a patient who have abdominal pain, abnormal bowel habits, diarrhea, blood in the stool, and whatsoever, and you are suspecting inflammatory bowel disease, always ask about the prevalence of extraintestinal manifestation, be it in the eyes, be it in the joints, be it in the mouth, be it in the skin. And if you have these extraintestinal manifestations along with abdominal symptoms, there is a higher prevalence of that the patient will be diagnosed with inflammatory bowel disease. The overall prevalence of extraintestinal manifestation is IBD is around 40%, so almost roughly more than one-third, a little bit more than one-third. And patients with one extraintestinal manifestations are more likely to have another one. So these extraintestinal manifestations should be known and should be sought when you are really phenotyping and characterizing your inflammatory bowel disease patients. So what is the mechanism? How does the inflammation in the gut can be associated with an inflammation outside? So there are multiple theories in research. Basically, it's the HLA, because immune dysregulation, when it involves the HLA loci, which are the antigen presenting cells, they might be the same might apply elsewhere, be it in the joints. And the other theory is what we call the antigenic mimicry, which means some antigens presence over bacteria can be similar to other antigens present in the joints, present in the eye, present in the skin, present in articulation, and what we call the cross reaction. So if the antigen in the joint resembles an antigen present on a bacteria that is really causing the inflammation in the gut, this is where you could have an inflammation at the same time in the joints. But these are all theories, but just to let you know that always think about extraintestinal manifestation whenever you have patient presenting with a chronic abdominal symptoms and you are thinking about IBD. Always search for the cutaneous extraintestinal manifestation, erythema nodosum, pyoderma gangrenosum. Always search for after stomatitis if they have recurrent oral ulcers with abdominal pain. This is high. There's a high likelihood that these patients might have Crohn's disease. So this is the importance of knowing the extraintestinal manifestations, because they are relatively prevalent. Almost 1/3 to 40% will have them, and patient might have more than one. Extraintestinal manifestation might appear prior to the diagnosis of IBD, simultaneously with intestinal symptoms, or even after resection of affected bowel segments. So they can occur before, with the diagnosis, after the diagnosis, and keep that in mind. So again, the way you look at them, they are really divided into IBD-related disease that correlate with intestinal disease activity, as I showed you on the first slide. Those should be known, because if you treat the activity of the disease and you really decrease it, the symptoms will decrease. The most known one that are correlated with disease activity are erythema nodosum, arthritis, scleritis, and episcleritis, and again after stomatitis, as I showed you in the previous slide. But there are also activity-independent diseases such as primary sclerosing cholangitis, which is an inflammation of the biliary tree, ankylosing spondylitis, which is an inflammation of the vertebra, and sacroiliitis, which should lead to really physical impotence and really chronic back pain and incapacity. Uveitis sometimes will not be related to the inflammation. Pyoderma gangrenosum sometimes is not related. It's not like erythema nodosum. It's not related to the most of the time to the inflammation of the gut. Why is that important? Because if you have this intestinal manifestation, first questions to answer: is it related to the activity or not? Why? Because if you bring down the activity of the IBD, the extraintestinal manifestation will get better. Whereas if you are dealing with spondylitis, sacroiliitis, you will know that not only you should really dictate the inflammation treatment, but you should also direct the treatment to specifically to these points. And importantly also, it will really impact on the choice of the medication, because there are some medication that really treat the intestinal inflammation and do not treat the articular extraintestinal manifestation. So again, this has diagnostic impact, but this also has therapeutic impact of knowing the extraintestinal manifestation and how do they behave to the treatments, because there are some treatments that really can cover both intestinal and extraintestinal manifestations, whereas there are some IBD treatments, I will not go into details, that only covers the intestinal inflammation. So this is again important for you to keep in mind. Again, to summarize what I've already told you in terms of extraintestinal manifestations with IBD, there are the extraintestinal manifestations that really parallel the bowel disease activity. When it comes to joints, peripheral arthritis usually parallels the activity, whereas axial arthritis, sacroiliitis, and ankylosing spondylitis are independent from the bowel disease activity. In the skin, erythema nodosum always follows the bowel disease activity, whereas pyoderma gangrenosum, which is a ulcerating chronic condition in the lower legs, does not parallel the activity. So treating the activity of disease is not sufficient, and you should have a therapy that really also acts on pyoderma gangrenosum. When it comes to ocular extra manifestation, again, episcleritis and scleritis are related to the activity, whereas uveitis might progress independent of from bowel disease activity. And when it comes to hepatobiliary involvement, primary sclerosing cholangitis, one of the really dreaded conditions of extraintestinal manifestation associated to IBD, usually is independent from bowel disease activity. This is an illustration of the extraintestinal manifestation, the skin extraintestinal manifestation related to IBD. To the left, you have erythema nodosum, which has really painful nodules on the anterior extensor surfaces of the lower limbs, and usually there are painful nodules that start by being red and they evolve into like an ecchymosis. They go into bluish, green, yellowish, and then they will disappear. Mind you that these, be it erythema nodosum, which is again parallels the disease activity, or to the right, pyoderma gangrenosum, which is a more extensive necrotic ulcerated inflammation of the skin that does not parallel the intestinal disease activity. These are not specific of IBD. They're not 100 specific, but they are, so they can be found in other conditions. They can be found in vasculitis, they can be drug induced, they can be associated with malignancy. So extraintestinal manifestations are not specific of IBD, but they are highly prevalent, and the most sensitive one should be known. Erythema nodosum and pyoderma gangrenosum are the most frequent one when it comes to skin-related extraintestinal manifestation. This slide shows you a nasty appearing pyoderma gangrenosum, be it on the right or be it on the left. This slide shows you what primary sclerosing cholangitis looks like at ERCP. ERCP is this is when we go through the mouth and we inject dye into the biliary tree and we take an abdominal radiograph, and you see there is a succession of stenosis dilatation, and there's a budding of the biliary tree. So it's a chronic inflammatory condition of the biliary tree, which is really found more associated with ulcerative colitis than Crohn's disease. And when it develops, it's a dreaded complication. Why? Because one, it does not parallel the disease activity. Second, it really evolves into cirrhosis, and there isn't any really effective treatment to slow its progression. So when you have primary sclerosing cholangitis, at the end of the road, in 10 to 20 years on average, you will go into cirrhosis and you will have to have a liver transplantation. So this is a very dreaded complication. Again, like any other extraintestinal manifestation, that are not always present, and they can be present outside the context of IBD. And so always look at it, and especially when you have any abnormal LFTs, when a patient has been diagnosed with IBD, ask for the gold standard to diagnosis is magnetic resonance cholangiopancreatography, what we call MRCP. And what we will be looking for is this is exactly the characteristic pattern of a succession of stenosed segment, dilated segment with rarefication of the biliary tree on the periphery because it's being inflamed and fibrosed and stenosed. So again, primary sclerosing cholangitis is important to keep in mind as an intestinal manifestation. And think about it when you have abnormal LFTs in a patient diagnosed with IBD. It is more frequent with ulcerative colitis than it is with Crohn's disease. If you diagnose a primary sclerosing cholangitis and you look for ulcerative colitis, you will find it in 85% of the patients. Whereas if you have been diagnosed with ulcerative colitis, only 15% will have an associated primary sclerosing cholangitis. These are epidemiological findings. Okay, so very dreaded complication, more prevalent in ulcerative colitis, and you need magnetic resonance cholangiopancreatography or endoscopic retrograde cholangiopancreatography to image the bile ducts and confirm there is inflammation in them. Uveitis is an inflammation of the anterior chamber of the eye. It's less prevalent than articular and skin extraintestinal manifestation in Crohn's disease. But again, the importance is whenever you have a patient presenting with abdominal pain, diarrhea, suggestive of IBD, always ask about a red eye, ocular pain, photophobia at the same time, or a previous history of having developed uveitis. Again, because most of the time uveitis runs unparalleled with the disease activity. The diagnosis is required by a slit lamp exam, and usually you should really consult an ophthalmologist with you to really deal with it. Ankylosing spondylitis and sacroiliitis are shown here in the slide. This is the sacroiliac joints, which are really inflamed. You have a thickening and a decrease in the interarticular line. This is how you diagnose it on KUB, on plain abdominal radiographs. But usually MRI is more sensitive for diagnosing sacroiliitis. So again, when you have sacroiliitis or spondylitis, these will run unparalleled with the disease, and you should really pick a treatment for the disease that really acts on the ankylosing spondylitis and sacroiliitis along with the intestinal inflammation. So again, this is another, I'm highlighting the importance of looking for extraintestinal manifestation whenever you diagnose your patient with IBD in order to really dictate the therapy they will be choosing, because you will need to choose, especially when the extraintestinal manifestation does not parallel the disease activity, you should really choose a therapy that really acts on both the ankylosing spondylitis and sacroiliitis and the intestinal inflammation, and not all anti-IBD therapies work on both. So think about that. Ask always about inflammatory back pain, about morning stiffness of the back of the vertebral column. And if the patient has these symptoms, always think about referring to a rheumatologist in order to get the proper rheumatological examination and the proper imaging to diagnose ankylosing spondylitis and sacroiliitis. Finally, we're going to address the treatment of IBD, the big principles. The goals of treating inflammatory bowel disease are to induce remission, so make the patient asymptomatic, and because these are chronic diseases, you should also maintain the remission by continuously using the medication. You should also aim to maintain adequate nutrition because, again, it will compromise the GI tract, and the GI tract is the main provider of nutrients absorption and digestion, and really required for us for the inflow of energy into the body. And you should always minimize the disease-related and treatment-related complications. And this is also all the art of treating inflammatory bowel disease patient, but because everything comes with a price. And the whole idea is to improve the patient's quality of life by improving his nutrition, his well-being, and the most important is to minimize the development of complications requiring surgery, such as we alluded to, be it toxic megacolon and ulcerative colitis, be it obstruction, or be it fistula development in Crohn's disease. One principle that you should really emphasize to your patient, and most of the time is really difficult to accept, is that neither medical nor surgical therapy will provide a cure. Okay, so the primary goals of therapy is to induce and maintain remission, and it's for the patient, and the patient needs to understand that even that he will feel very well on medication, he should not stop the medication because sooner or later the disease will recur. So it's a chronic disease. Who says a chronic disease says a chronic medication and therapy. When it comes to ulcerative colitis, because colitis is really limited to the colon, surgery might be curative, but it comes at the expense of higher complication and should only be reserved to complicated ulcerative colitis, because nowadays we have a very efficient drugs that really control on the long term the inflammation of the colon and the gut. This is a brief list just for you to know the available families or class of medication, the aminosalicylates and the immunomodulators. In the immunomodulators, we have what we call the azathioprine or Imuran, the methotrexate or cyclosporin. You have the biologics, which target anti-TNF alpha, interleukin 12, 23, or the integrin. And you have the small molecules, which are the JAK inhibitors, and you have the mainstay of therapy that has been there for decades in the treatment of IBD, which is the steroids. And so nothing is as efficient as steroids when it comes to IBD treatment, but nothing has the spectrum of deleterious side effects such as the one associated with steroids. So steroids continue to be the mainstay of therapy for acute severe attacks, but more and more we're relying on other therapies to avoid steroid consumption, because steroid consumption on the long term is very bad and is associated with the development of multiple side effects. Because we have nowadays really efficient therapies for IBD, surgery should only be reserved for complications. So the indication for surgery in IBD include complications such as intra-abdominal abscess and fistula, medically intractable fistula, fibrotic stricture causing obstructive symptoms, toxic megacolon and ulcerative colitis, intestinal perforation, bleeding, and the development of dysplasia and cancer when you are surveilling patients who have chronic long-standing inflammation for more than 10 years with colonic involvement. Patients with symptom refractory to medical therapy used to be considered more frequently to surgery, but nowadays with development of other therapies than glucocorticoids, it's really not the first line therapy compared to medical therapy. So surgery, again, the main take-home message in IBD should be reserved for complication, perforation, bleeding, obstruction, fistula, and abscesses. And we have a lot of treatments that really control the disease. And the idea is not to go to surgery unless we are really pushed into it. Finally, this slide just lists the most common surgeries performed in Crohn's disease. ICR stands for ileocecal resection because the ileal region is the most prone to stenosis. So the surgeon will take out the ileum and the part of the cecum to remove the stenotic segment. Segmental resection in the small bowel, because Crohn's disease can involve the whole bowel, and whenever there is stenotic segment, the surgeon can cut it away. This is called segmental resection. Stricturoplasty is when there are multiple sites of stenosis in the small bowel, but you should not resect. You cannot resect a very wide area in order to avoid getting into malabsorption. So we can do a stricturoplasty, which is a surgical dilatation of the stricture to really avoid obstruction and occlusion. When it comes to ulcerative colitis, when the colon is inflamed in totally, the TAC is total abdominal colectomy. This should be completed with what we call ileal pouch anal anastomosis. So once you take out the whole colon, you might get the patient a small cure, but you should also restore continuity of the small bowel. You will really make a small reservoir called a pouch from the ileum and anastomose it to the anus. This is called ileal pouch anal anastomosis, which is really done in 2 to 3 steps. And sometimes in the old days, when they didn't have other therapies than steroids and people field steroids, there was a radical solution of removing the whole diseased bowel and putting what we call an end ileostomy. This is nowadays not very frequently performed.